There we go. Hi, everyone.
Hello, good evening.
Thanks for joining us. We're planning to revisit a topic that we've talked about in the past, and certainly in our other webinars, anything we've talked about using stem cell therapy to manage an orthopedic condition, be it a shoulder, a back, or a knee. But tonight we want to dive deeper into what that term means. What does stem cell mean? Because it's a very broad term that can mean a lot of things to a lot of different people.
That's true. And then even in the scientific community, the word stem cell can also, spark a lot of debate as to what actually is a stem cell and should we call it stem cells but for the purpose of this talk, we'll define it as stem cell.
Yeah, and the main reason we like to keep it that way is in the general public, the term that's being used is stem cell. So we want to use the verbiage that our patients are using in order to communicate effectively. So when we talk about the stem cells, there are two broad categories. One is called allogenic stem cells, and the other is called autologous stem cells. So that term allogenic means that it's coming from someone other than the host. So if you're the patient, someone other than you. And then autologous means that it's coming from you.
Correct. And there's advantages and disadvantages to both, right? There's here in the United States, for the purposes of orthopedic procedures that we do here, joints and spines, we can only use autologous stem cells.
And that might sound like a limitation, but in reality, those might end up being the cells that work best because they're cells from your body designed to heal your body. And we're simply being the technicians that are taking them out of you, concentrating them, and then being specific about what we're retargeting to them, to you, back into your own body.
Yeah. So there's advantages and disadvantages to both. So for autologous stem cells, for the applications that we do here at the Michigan Center for Regenerative Medicine, where we treat orthopedic conditions of the joints and spine, we want cells that are viable. So essentially cells that are alive, that are able to replicate, send signals, and be biologically active. Allogenic stem cells, since they come from a different source, a lot of times they're packaged and frozen and then thawed out and injected. It's true that they have a large amount of cells in them, but the whole process of freezing and processing eventually kills the cells. So when you look at them in the microscope, comparing with your autologous stem cells that's derived from you can see that the autologous stem cells are alive and viable, and for our applications, work better.
So larger studies still needed. Using our outcome registry is one of those sources that we hope to really shed light on whether there's a therapeutic benefit to using autologous over allogenic or vice versa. Another big question that we oftentimes get is, are you using embryonic stem cells? So that's a type of donor allogenic stem cell that's when an egg and a sperm come together, they form an embryo, and those cells are meant to become an entire human body. So while that early science and research was very exciting using those types of cells, in reality, when tried to apply clinically, they don't work. They've never really found a disease process or any sort of clinical indication where they seem to be able to slow their differentiating or their pathway into specific tissues. And so most of the research that I'm familiar with anyways has really gone away from embryonic stem cells. So while it's a big trigger, emotional trigger for a lot of folks, and concern that we're using umbilical cord cells, or embryonic cells, that's nothing we've ever done,
right.
Nor do we have any plans to venture into that sort of research. It's just something we like to mention that we're not using embryonic stem cells here.
Yeah. And then also, there are other sources of umbilical cord cells and amniotic, Wharton's jelly type stuff too. We've been approached by vendors about that as well, and it's something that I think there's a lot more research that has to go through as to whether it's viable for the applications we're trying to do. But for now, we're focusing primarily on autologous stem cells until we know otherwise.
Yeah, and part of that's a limitation of practice in the United States. Right now, there aren't any allogenic products that are able for us to access and utilize for the purposes that we treat here. So any of those sorts of studies that are using, and they're confusing terms because they all involve babies, but embryo or umbilical cord cells, amniotic cells, the Wharton's jelly, the birth tissues, all of those being used for orthopedic purposes are being done outside the United States, and being able to use a common registry where we can compare outcomes has been a bit of a challenge. So we don't have those direct comparisons yet. But what we do know is what we're doing here is working extremely well for our patient base. Yeah. And so we're excited to talk about more of those types of treatments, the stem cell therapies that we are offering here, being adipose-derived or bone marrow-derived autologous stem cells.
Correct. So for the longest time, bone marrow stem cells have been our mainstay for what we use when we talk about a stem cell procedure. Which is separate from PRP and prototherapy, which are other treatments that we use. But for the purpose of this talk, we talk about bone marrow stem cells. The idea is we obtain the bone marrow stem cells from the bone marrow. We extract it from the iliac crest. And the reason that we extract it from that is because there's studies that actually show that this is the richest source of stem cells from other sources you can get bone marrow from. So we extract it from there. And then from there, we process your bone marrow and extract the stem cells from there. And then we re-inject that to tissues and areas that we need to address. Talk about the adipose.
Sure. Yeah. So our and the other option for stem cell storage in your body are the adipose cells, and it's actually not the yellow fat adipose cells that we're after, but it's the vascular cells that are stored in our adipose tissue. So it's very much similar to the cells that we get from the bone marrow. There are some slight differences in the percentages and the quantities, but essentially the same type of stem cell that we're going after in the bone marrow is the same type of stem cell that we're going after in the fat. A different process for obtaining it, doing a lipoaspirate procedure versus a bone marrow aspirate procedure. Different process for separating them. We don't use centrifuges like we do for the bone marrow. We use some sort of micronization technique, whether it be different filters or different levels of screening or sifting out the larger adipose cells from the smaller stem cells. But it's a FDA compliant technique where we can separate the tissues and the cells that we want from those that we don't, without doing any kind of manipulation of the cells. There are rules when it comes to processing and re-injecting stem cells in a patient, and one of those is that you don't do anything to the cells that classifies as a manipulation of the cell.
Right. And within the tools that we use here, we try and adhere to that as close as we can. The good thing is we're still able to get really good outcomes from it.
Yeah.
We've worked with a lot of vendors on that too. So what is it in stem cells that is so controversial, and what is the stem cell? What's in the stem cell that actually makes it work?
Yeah, so that's a question that a lot of people are trying to figure out. The person who coined the term stem cell, the type of stem cells we're using are called mesenchymal stem cells, and the mesenchyme term comes from the different layers of the human embryo as you're developing, and the mesenchymal tissues develop into things like connective tissues. Mm-hmm. So our bones, our ligaments, our tendons, our cartilage, the things that we treat. So the types of conditions we're treating are all mesenchymal type conditions. So it makes sense that we would use the mesenchymal type stem cells for the orthopedic applications that we treat. And while we still like to use the word stem cell, the reality is these cells don't end up growing and dividing and becoming the end tissue that we're trying to treat or grow. So for example, we're trying to grow cartilage in your knee or regenerate a rotator cuff tendon. The cell, if you put a little label on it, will never end up dividing and becoming a cartilage tissue. It will never divide and become a tendon tissue. So how do we then get regeneration of that tissue if these cells aren't becoming the tissue?
Yeah, so it's actually really interesting. It's kind of mind-blowing when you kind of think about it. So Dr. Arnold Kaplan is the godfather of MSCs. So he's actually wanting us to stay away from using mesenchymal stem cells and actually call them mesenchymal signaling cells because of exactly what you said. These cells are not becoming the cartilage. But what he did find out is that it's part of this cascade of signals and chemicals that happens in your knee. So believe it or not, you actually have MSCs, these mesenchymal stem cells in your knee itself, in your cartilage, in your bones, in all your tissues. What happens is with arthritis or injury or trauma, the normal function of the MSCs to repair and regenerate kind of goes haywire because you have this chronic inflammation that's happening on there. So they become senescent. So essentially they become deactivated. What we do know is when we inject MSCs and fresh stem cells in there, it activates these chemical signals in these cascades, which makes these MSCs that's already in your tissue, in your cartilage, and in your knee or your joint or your spine or your disc to become active again and revert back to regeneration. So exposing them to fresh MSCs keeps the MSCs that's already there to be activated. So it's a really complicated dance that they do. A lot of it is signaling. A lot of it is a paracrine effect, like a hormonal effects. There's chemical signals that happens there, but it all leads to creating this homeostasis, this normality in your joint, where the shift from being degenerative and painful and arthritic to being regenerative.
And it begs the question whether it's the signal, then that's the key component to it. My personal belief is there's more to it than just those signals, but the signals that these cells kick out are overall classified as exosomes or extracellular vesicles. So there's some evaluation of whether these exosomes, being acellular, can be isolated, bottled up, and can they be used as a subsequent or as a substitute for the mesenchymal stem cell. Again, we need to do more studies. We need to track our outcomes. It is a therapy we're familiar with here, but there are restrictions in the United States right now in using anything other than what comes from the patient. So an autologous source of the exosomes would be okay to use. Allogenic right now are still considered outside of what we're allowed to utilize for regenerative medicine in the United States.
Yeah. So for the two sources of stem cells that we have, how would you decide when you consult a patient, which one do you recommend as far as, is it adipose or is it bone marrow stem cells?
Yeah. So for me right now, I'm still in the adipose, or excuse me, I'm still in the bone marrow camp. I've used adipose. I've combined it with different therapies. But the main reason for me, I think bone marrow is better, is I can quantify it. Right now, I don't have a method for quantifying the substance and the number of MSCs I get from a lipoaspirate. It's a technique that's being evaluated with our lab company that we use, Gray Ledge Technologies. They are doing investigations into techniques so that they can give a quantification. But for me, being able to know how many cells and what dose essentially of stem cell I'm giving a patient is important to me. There are certainly good studies comparing bone marrow aspiration from lipoaspiration, and it appears that there may be more MSCs in a lipoaspirate of equal volume to a bone marrow aspirate. But right now, with the equipment we have, I can get higher volumes in the bone marrow aspirate than I can get out of the lipoaspirate, and then I get a quantification, and I know that sample is of an adequate dose when we're going to go and do the procedure, which for me is an important variable in getting a good outcome. If you inject the wrong dose of any kind of medication, your likelihood of having a positive outcome go down. So while we don't know exactly what that correct dose is for stem cells yet, we are getting more and more information as we collect more and more data. And here at Michigan Center of Regenerative Medicine, we do have minimum thresholds where we want to have our doses above. So that is one of the things that puts me a little bit more towards bone marrow over fat.
Yeah, same thing. I think the jury's still out with fat, right? So from a, I guess, chemical point of view or biological point of view, they analyze both fat and bone marrow stem cells, and they have the same types and kinds of chemicals and proteins and stem cells on there. Theoretically, Dr. Navi's right, you do get more MSCs per volume of fat than bone marrow, just by the nature of fat. I think as far as limitations with processing, I agree with you. It is kind of hard to get large quantities of that of the fat for how we process it. The I don't think there's been really any great head-to-head yet as far as bone marrow and fat as far as outcomes. There's some studies in shoulder data, some knee data, where it shows that adipose may be advantageous, but there's other side of the coin also. Bone marrow has been really effective in treating these things as well. So I think it's just a matter of, at this point, I think I treat them as equal, right? For us, we've been doing bone marrow concentrate preparations and injections. We've been having really good outcomes for now. So I kind of just present the two ways of, it all comes down to me on how I present it to the patient as far as what they prefer as far as the site of source. So patients sometimes say, I don't want a needle into my bone. I'd rather just get a liposuction. Okay, then we'll do the lipoaspirate. Or the other flip of the coin, well, I want to see you guys have more experience with bone marrow. There's more data on there. They like the whole idea that you can quantify. So yeah, it makes sense to do the bone marrow. So, but I think from an outcomes point of view, I think from the data that we're seeing so far, you can't go wrong with either one.
Any reason not to do both?
That's, I think, the next step, right? I think the only reason, I think there's a value to doing both, right? Because theoretically, fat can form a scaffold in certain areas, right? So if you have a degenerated joint, put some fat in there, you can potentially create a cushion and some scaffold to build. I think the biggest problem would be cost, right? I mean, these procedures are not covered by insurance. They're all out of pocket. Having to do both bone marrow and the lipoaspirate being PRP means like you're processing 3 times. There's 3 times the cost of the lab. But I think, in the ideal scenario, it'll be, let's say you're treating knee osteoarthritis, I would say intraosseous BMC in the bone, micronized fat in the joint space, and throw in some PRP to the ligaments and tendons, and that's the trifecta.
Yeah, I agree.
Yeah. Anyone wants to volunteer?
Yeah, unfortunately, we don't have a whole lot of discord between how he practices and our practice, but we do, I think, bounce a lot of ideas off each other, not always live in front of the camera. So
we never talked about that.
No, that was a first. Yeah. That was a first. But just overall, the idea that stem cell being still the term I use when I'm talking about what I think is the strongest, most powerful regenerative option that we have, and while there's problems with the term, or it was certainly within the scientific community, I think it's important that we arm our patients with follow-up questions when they're asking other clinicians or practices about a stem cell procedure. Okay, where do you get your stem cells from? How do you know they're alive? What's the cell count that the dose essentially that you'll be injecting me with? I think those are all valid and
how
fair
do you
questions to
track
ask.
your outcomes, right?
Knowing what you're injecting and being able to track and get a follow-up from a percentage of patients that you're treating, I think is a really important part of deciding where to go or if to undergo a regenerative procedure over any kind of traditional pain management option or surgical option.
Yeah, there's definitely advantages to doing regenerative medicine. It's not invasive, minimally invasive. It's very safe to do. Recovery is a lot faster. So there's a lot of advantages to that. There is still room for surgery and injections, but I think right now with the ability to do regenerative medicine, it does give patients another option for that. Here's a question.
Yeah, we got a lot of questions coming in. I would love to save enough time to answer some of them if we could.
You want to?
Go ahead.
Okay.
Yeah.
So I kind of get this question a lot. I'm sure you do often too. It's I've heard, or the patients have heard, that as you get older, your stem cells aren't going to be as good, and that's the justification for using embryonic or umbilical or birth tissue type cells, is because it's young, it's not exposed to any toxins. How do you respond to that?
Yeah. So empirically, I can tell you we've treated plenty of patients in their 70s, 80s, and even 90s, and had success. So we know that stem cells aren't gone over a certain age. There is no absolute end age where you're not a candidate based on age. Overall health is more important to me than chronological age. We're taking out your tissue from your body and re-injecting it into your body. If you are in a bad health state, a regenerative procedure probably isn't going to be a great idea for you. But that doesn't get better by using a donor tissue. And the reason is, as we described, these cells aren't the cells that grow and become the end tissue. They're signaling cells. They're telling your body cells to grow and divide. So no matter whether you're taking your own cells out and using them as the signal to tell your own cells to grow and divide, or using somebody else's cells that again are telling your own cells to grow and divide, the end result comes from your own cells growing and dividing. So we definitely need to track it. I'm not going to sit here and tell you that there's absolutely no way that a donor cell is going to perform as well as your own autologous cells. But my intuition and what I've seen clinically, taking your own cells out and putting them back into your own body works extremely well. And it's very safe. The risk of any kind of infection or any kind of rejection from using a donor is virtually none, because they're your own cells.
Yeah. I agree. I think there's more research to come. If there's a way that, I know there is a way, but I think viable tissue is probably the key word we want to look for. But what I usually tell my patients too is that your stem cells, your cells in your body from birth till your teens, your 20s, up to your 90s, are exactly the same cells that can do the exact same job. So the quality of your cells stays exactly the same, whether you're 85, 95, or 15 years old. The difference is the number of stem cells that's available decreases as you get older. If you think about it, because there's a lot more repair that needs to happen, so the volume of your stem cells gets diluted. And that's the value. So the way that we get around that is by being able to concentrate the stem cells that you have to a large volume to meet the minimal threshold requirements that we know are going to be effective in treating you. So we go for the highest concentration that we can get. So at the end of the day, you're still getting very high quality stem cells from you that we know are effective and has been fixing your body all your years, and concentrating it in a large number where it's going to be effective. So the argument that your stem cells aren't as good as you get older is no longer true. It's as long as you're alive, as long as you're still healing and your body's healthy to heal, it's going to work.
Another question we get a lot of with the bone marrow aspiration is, it sounds painful. Does it hurt? And then how long before your body replenishes those stem cells?
Yeah, well, you can speak to that.
All right. So so I've definitely I can speak to the process of having your bone marrow aspirated. So I've had it done twice. Once by Dr. Santa Ana for re-injection into my spine. We've done a previous webinar about my experience as a patient receiving a regenerative procedure. And I can tell you it's a very minimally painful procedure, done with the right technique in the right hands. Local anesthetic, ultrasound guidance, finding the right target, numbing everything between your skin and that outside of your bone called the periosteum. And the technique really of numbing that periosteum is critical. So getting a good lidocaine agent on top of that periosteum. And then think of that as being like the egg or the shell of an egg. So it's really the pain of going through that shell. And then once you're in the middle of the egg, there's very little pain from that. So if I had to rank on a scale of 1 to 10, I wouldn't call it a 0. It would be a 2. You could feel it. The numbing agent was probably the worst of it. And then a lot of pressure when the needle's in the bone marrow. And then as you're aspirating it out, it just feels like a negative pressure, like someone's trying to lift you up by a strong suction cup on your back. But it's not painful. It's just strange.
Yeah.
So nothing I would recommend being sedated for. It's an option. We have sedation here if it's something that's very terrifying, but done right, done with the right technique, it's really not painful.
That's right. And a lot of our patients too will kind of echo the same things that you said too. It's like probably the worst part is the numbing part, and then, like you said, that negative pressure when you're pulling up from the bone marrow, slightly uncomfortable. But again, it's a quick procedure. Most of our patients do it under local anesthesia. We do have the option for sedation if that's needed. But yeah, it's been working pretty well.
And then how soon after, if you had a bone marrow aspiration, how soon after would you recommend somebody wait before doing another?
So I think the discussion was, or the general consensus was, like, you want to wait at least 6 to 8 months just to make sure that everything gets your bone marrow gets renewed and refilled. And if you think about it, if you undergo a regenerative medicine procedure, it's not just the stem cells that you're pulling off from there. It's all of your body's healing mechanism working together. So not to be corny, but your life force is working to kind of repair that. And that's a finite source. So you want to be able to recover that. So if you're going to go another regenerative procedure, you want to be able to at least have that gap to kind of replenish it.
And then we're getting quite a few questions about different areas of the body that stem cells, can they work for hips? Can they work for knees? Can they work for spines? Short answer is yes. We've done, if you go to our website and go through our previous webinars, we've done various webinars on all those topics, specifically kind of our approach to back pain and using stem cells to help back pain. Same thing for knee pain, same thing for hip pain and shoulder pain. Ones we'll be revisiting as well because our approaches are evolving as the field is evolving. So it'd be good to update those, but there are some historical ones if you'd like to look at those again on our website in the video column.
Yep.
I saw another one here for a question about, which is a good question, and about lidocaine and stem cells, and is lidocaine deleterious to the stem cells? So we use lidocaine, so that's a good follow-up question.
Yep. So we use lidocaine to numb the skin and the surface, but we can't expose the stem cells or the PRP or any of the orthobiologics with lidocaine because it does affect the efficacy of the cells. Essentially, can make them useless, because of their high acidity of lidocaine.
Yeah. So it's one of the reasons the procedures hurt. So when I talk about the bone marrow aspiration, I tell you, boy, it's barely painful. It's barely painful. Getting it injected, the needle placement, barely painful. We use lidocaine to numb the skin and track of the needle. But for example, if we're injecting your rotator cuff, we can't put lidocaine into the rotator cuff and then put PRP on top of that. And the reason being is it will deactivate some of the efficacy, if not most of the efficacy of the PRP or the stem cells. Yeah. So those procedures, those parts do hurt. That pushing of the stem cell, pushing of the PRP into the tissue does hurt, but we have ways that we help mitigate that as well, either with the use of IV anesthesia or nitrous oxide, laughing gas. We use that extensively in the office. Extremely safe, extremely effective, and really mitigating that painful sensation.
Yeah, I think it's just, when I talk to patients constantly about these procedures, I tell them that, once the orthobiologic hits the tissue, it just creates a big inflammatory response. Even though it's a small amount that we're putting in there, it just creates a lot of pressure, a lot of inflammation. It creates a lot of pain, but it's short-lived. It's most people are able to tolerate that really well. For people who are not fans of pain, they can have the option for anesthesia, put to sleep. But typically, if you have it done under local local anesthesia, we do the procedure. It's going to be sore and inflamed for about maybe 10 minutes after the procedure, and then it starts to die down and becomes a lot more tolerable. So if you can tolerate the pain for about 15, 16 minutes, then you should be fine.
Yep.
And a lot of it has to do with location of where the injection is too. So I think for shoulders, it's not too bad. For knees, it's not too bad. Sometimes the hips are kind of plus minus. I think smaller joints are a lot more sensitive. So feet, ankles, hands, wrists, elbows, those types of things. Also more chronically degenerated joints also I feel like a little more painful. But so it all depends on tolerance.
Yep. A lot of questions. We appreciate them. I don't think we'll have time to get to them all. We like to leave these webinars under a half hour, and we're pushing that time right now. So everybody, thank you for tuning in. Really appreciate it. Would love to get your questions. If you want to give us a call, we'll set you up. We do telemedicine visits if you're not close. But if you're in the Rochester, Southeast Michigan area, we'll let you come in for an in-person consultation, see if we can help you out. Michigan Center Regenerative Medicine, 248-216-1008. Also, regenerativemedicinemichigan.com is our website. Feel free to reach out to us, whichever is the easiest for you.
All right. Thanks for tuning in, and good night.
Thank you, everyone.